Good evening, all. I hope you can see me and you can hear me. Welcome to the 15th episode of the very popular Master Techniques. My name is Maneesh Bhatia. I'm a member of the Education Committee of BOFAS. And on behalf of the Education Committee and the IT Committee, which plays a big role in organizing these very educational and highly appreciated meetings, we are going to invite our two guest speakers. The topic we have chosen for tonight is alternative options to joint fusion in hallux rigidus. And like me, I think you would see patients in your clinics where patient has arthritis, which is such a common problem in the foot, arthritis of the big toe, and they have got taboo about fusion. They don't want the joint to be fused, and they want to know about the alternative options. So I think it's quite a relevant topic both for clinicians as well as for patients. But obviously, clinicians need to be educated first, and it's a great honor that we managed to get two excellent speakers who are going to talk about different approaches for hallux rigidus. Both would be, however, talking about avoiding joint fusion surgery. So I would welcome our first speaker, Alessio. He is a good friend. Alessio Bernasconi is practicing in Naples. He's very active researcher. He has just become the member of scientific committee of EFAS, and previously he has chaired the youth committee of the EFAS, has written a number of publications, and is an excellent speaker. And today, Alessio is going to give us his tips and techniques, what he does mainly with the first metatarsal osteotomy, the Youngswick osteotomy. So I will now pass it on to Alessio so that he can take us through his presentation. Looking forward to it, Alessio. Thank you.
Thank you, Manish. Good evening, everybody. So thanks again, Manish. Thanks to the BOFAS Educational Committee for inviting me, and thanks to BOFAS in general for the opportunity to be here. So I'm going to now share my screen. Give me just 1 second. Okay, can you see my screen, Manish? Just
Yes.
feedback?
Yes.
All right, so my talk is going to be Youngswick osteotomy for hallux rigidus. So just this is the way I have divided this talk. Just a bit disclosure. We are talking about alternatives to fusions, and that's not a way to say that I do not perform fusions, because essentially when you have a stack hallux with like no motion at all, probably doesn't make sense to think about osteotomy. But leaving this aside, we're going to just discuss about Youngswick in general. We're going to consider how to perform it, and then just reflect a bit about different points. So this is what we're talking about. That's just daily practice, nothing very specific. What you can see in a clinic with whatever young lady coming and complaining of pain on the hallux, not really saying there is a bunion, because there is not, of course, saying that she has a sensation of rigidity, and there is probably a dorsal bump that gives problems with the shoes. So this is probably a story that you all know very well. And when you go and try to classify, you know that there are many classifications for that, but generally speaking, the coupling one is probably the most used one. And there is agreement that for whatever is conservative, and when I say conservative, I mean joint preserving, we can consider grade 1 and grade 2. And grade 2 is like 10 to 30 degrees of motion. However, as a provocative thought, if you consider that in foot and ankle in general, probably in orthopedics, but especially in foot and ankle, we are moving towards the moment where we really consider less and less radiographs, and we consider more and more the function. Like, for example, for supramandibular osteotomies or Zadek osteotomies are just two examples of, let's say, bad radiographs, which can still bring us to good clinical outcomes. So this could bring us to consider Youngswick or other joint preserving procedures also for grade 3 and grade 4. Probably grade 4 is a bit too much, but for grade 3, I think it's something that could be discussed. So we go back to radiographs. That's just another case. And this is just to highlight how you always have to consider biplanar radiographs, because like on dorsoplanar view, it seems that there is no joint space at all. But if you look at the lateral view and the sagittal view, essentially a lot of that space is occupied by osteophytes, and actually there is still a joint. You can see in there. And clinically speaking, that's the dorsal bump we were talking about. And you may discover that there is still some hope. No, there is still some motion in the hallux, as in the picture on your right. And this is what we want to do. That's the end of a Youngswick osteotomy. So let's see how do we get there. So how to perform it. Probably different approaches. You know that our science is not perfect, and orthopedics, I mean. So there are multiple ways to do a thing, and this is just my way. Like patient supine with the ankle tourniquet, and on the red line you see how you place your incision is more or less the same place of a chevron osteotomy and of a scarf osteotomy, probably just slightly more dorsal. And this is how you perform your capsulotomy. And again, this is quite standard. You go into the joint, and when you do your dorsal capsulotomy, probably as compared to a chevron or to a scarf, is a bit more tricky, just because you got osteophytes there, you got a lot of bits of bones that are in the way. Anyway, at the end, you are exposing the joint, as you can see here in the video. And then the first thing is just do a calectomy. This seems quite
Sorry,
oblique.
Alessio.
Yeah,
I can't see your slides moving.
Where are you now?
We are on your basic slide with the classification.
All right. But
I think there's a lag. They are moving, but it's a lag.
So, okay. So which slide are you seeing now?
Which slide are we seeing? I am still on the classification slide. For me, it's not moved.
No, it's actually moving, but there's a slight lag, which is normal.
Okay, so tell me if I can go on, or I mean, if you now, do you see the X-rays on the slide?
Yeah. So
Maneesh?
I see the previous slide, but I see the X-rays. It's fine.
The X-rays. And
if
now
any attendees can please let us know if they have any issues. I can see it fine.
And this is clinical pictures.
Yes,
you can see them.
The clinical photos.
Okay, great. Okay, and now the X-ray, and I go. So this is a video. Just confirm you're seeing a capsulotomy.
I see the video on mine.
Okay, that's great. So I assume it's all right. You just stop me if needed. So that's, again, the capsulotomy. And on the next slide here, there was the joint exposure with essentially opening of the dorsal capsule, which, as I just said, I mean, can be a bit more difficult because of the multiple dorsal osteophytes. And then you expose your joint, and in the way you're seeing in the video, you perform a dorsal calectomy, which is, I mean, the normal calectomy, nothing really special about that. And then in this part, you can see the medial exostectomy, essentially. And again, this is not probably described in all cases, but I do perform it just in order to have a more regular surface to perform than what I want to do. And that's just sort of an X-ray with a drawing on, just to show you what is my intent. So I know that I want to do a V shape as for a chevron. Just in order to be a shortening, it needs to be there a recut of the dorsal arm. And also remember that the lower arm is the one that is gonna help you to plantarflex the metatarsal head. So the two targets of your osteotomy, let's just underline this, are number one, shortening, I mean decompressing the joint, and number two, plantarflexing. And this is the way you perform your uppercut, but again, also here, nothing really special as compared to a normal chevron. That's the lower cut, and that's the V shape that you can see on the bone. And then you go there for the recut. So about this, there would be a lot to say, because if you look at publications, at literature, essentially there is no real agreement about how much you have to remove. Like generally speaking, I would say 2, 3, or 4 millimeters, but sometimes I must admit that I go at 5, which is quite a lot. But if you consider that most of these halluces I have metatarsal index plus, which means that the first metatarsal is longer than than the second metatarsal. You probably have room to go and shorten the compress a bit more. And then you remove the interposed bone, which is in the middle here. And here you can test your shortening and the movement of your metatarsal head, and you can do the same also on the fluoroscopy. This is not something that I would do normally. It was just for the sake of recording this presentation. And this is just a sort of before shortening and after shortening, intra-op fluoroscopy. Again, of course, I didn't touch at the joint. You can still see the osteophyte on the medial part, but there is no evidence that going in there and having a better X-ray will give you a better result from this point of view. And then there is just screw fixation. Here you can use 2.5 or 3 millimeter, the standard that you would consider also for a chevron or a scarf osteotomy. And this is already how you appreciate on your fluoroscopy what you have done. So with those two lines, I have just indicated how much I have plantar flexed and shifted from distal to proximal the metatarsal head. And here with multiple fluoroscopies, I'm going to show you in terms of movement how satisfactory it can be. Now, this is with an open capsule. We agree on that. So this is never going to be the final movement. But on the other side, it gives you hope that the final movement again will be not so bad. And this is just the same radiographs, just compared on the same screen to give you an idea of plantar flexion and dorsiflexion. And that's the same thing just seen from a dynamic point of view, like we know in order, number one, to test how stable is your screw, and number two, to check what is the movement. And that's the final closure. So again, just 4 stitches is, of course, it's standard, but it's not minimal invasive, but again, it's not generally a problematic area for wound issues. So just general considerations. First thing, this is probably what you want to have. It's just one case. It's not evidence. It's not even expert-based. It's just one example of what you can have. Like in this, when I saw this lady, it struck me how her big toe was slightly dorsiflex, but this was something that I wanted going back in surgery, because essentially I tried to let her gain a bit more of dorsiflexion, and in the end, she was very happy, and this is a video she sent me 1 year after the surgery. Probably she would have been able to do that after 5 or 6 months already, but this video was quite satisfactory. And that's another case, just 10 months follow-up. Why I picked up those radiographs? Because this is an example of metatarsal plus. This is the thing I was discussing earlier, and there I've shortened a bit more, but I'm not afraid about that. Like in this case, the parabola is still quite good, and on the sagittal view, you can really appreciate, I think, what's the true power of this osteotomy. I mean, when you decompress and you plantar flex, you can really improve the congruence of the joint, and this is what I try to show on those images. And these are just other radiographs, again, index plus, which is quite common in my practice. I don't know if there is a relationship of cause effect with Hallux rigidus, but it's something which has never been really demonstrated to the best of my knowledge. So is there good evidence behind Youngswick? There is evidence. I don't know how good it is. There are papers like this one, that's an Italian group from Milan, showing that you can delay a fusion at 13 years, which is not that bad. And you can also see here a picture I took in Toulouse like 10 years ago when I was there as a fellow. And Nazim Mehdi was one of my mentors there, and he's never been a big believer in anchor replacement. So in his words, anchor replacement should have been presented to patients as a delayed arthrodesis. So I'm just borrowing that concept. Maybe Youngswick could be considered as a delayed fusion or delayed arthroplasty. We will see. Isn't fusion a good option? Actually, it is a good option. And there are also studies, and also like this one, which came out March of this year, also demonstrating that also in young patients results are good. Anyway, if you look at the literature a bit more in detail and you look at those papers, for example, in the lines, you will find that you need a careful patient selection for your fusion, and also that outcomes are not so predictable, especially in athletes. So it's something that, yes, let's say is good, but should be probably even more discussed. Alternative germ-preserving osteotomy is probably the Moberg osteotomy, and about that I have really no experience, so I'm unable to add anything relevant about that. Can we go minimal invasive? Probably we can. That's the only paper I found published by George Del Vecchio, was published a lot on minimal invasive, and essentially what it describes here and being called shortening pelco is essentially a Youngswick osteotomy just performed in a minimal invasive way. I must tell you that I do perform minimal invasive surgery. I do Mika, I do Zadek, I do calcaneal osteotomy. However, considering the Youngswick osteotomy, my personal thought is that in my hands, this wouldn't work. I mean, I haven't tried yet, so probably in a few months we could rediscuss that. Anyway, I think you probably need a really delicate control of the position of your bones to make it work. And when I do percutaneous surgery, I do control a lot of things, but really not all of them, at least in my hands again. Open questions for the future, or also for this webinar if you want. What's the exact point where an hallux limitus becomes an hallux rigidus? So this is something which has never been defined to the best of my knowledge, and it's something useful because if we do studies, we need to include selected people, like we need to define the population we want to study. And sometimes if you look at the literature about those kind of osteotomies, there is a bit of confusion about this terminology. Second thing, the best direction of the cut, especially the lower arm, which is the one which is plantar flexing your metatarsal head. And also about the upper arm, like how much do we need to shorten really, how much we have to, and how much we can shorten, which is a bit complementary. So just in conclusion, Youngswick technique, as you have seen, is not certainly a difficult procedure. I mean, anyone who has done forefoot surgery, like an experience in scarf osteotomy, I think can quite easily do that. Indications are probably getting wider. I don't know if wider also minimal invasive. It's something that the future will tell. It could be presented as a delayed arthrodesis. So I must admit to you that this is the way I do present this to most of my patients, telling them, listen, if I can save your movement, I'm happy. But in case we fail, like in 1 year, you come back, you have movement, but you also have pain. You have to be aware that we may need to do a sort of stage 2, go in there and do a fusion. Thank you very much for your attention.
Thank you so much, Alessio. If you can stop sharing now. Excellent. Thank you very much. That was a very concise and very practical talk with very clear message. And I'm sure there will be lots of questions people would want to ask. So let's move on to the second speaker, Mr. Clough, Tim Clough. He's a consultant in Wrightington for a very long time. Doesn't need much introduction. His main interest is ankle arthroplasty. He has done a number of publications, but his second love, I believe, in foot and ankle is Silastic, fantastic Silastic. So I look forward to hearing from Tim about how to avoid joint fusion surgery.
Okay, thank you very much, Maneesh. Thank you for inviting me. So I'm just trying to get to share my screen. So, am I on? Am I sharing screen?
Yes.
Perfect. Okay. Let's hope it goes past the first slide, or maybe not, as the case may be. So, I've been asked to talk about alternative options to joint fusion. So obviously you've heard now about the Youngswick osteotomy, and I'm just going to give you alternatives because not everything in life has to be fused. So obviously you all know the epidemiology of Hallux rigidus, often age more than 50, 6% are bilateral, more in female than male, and most commonly primary OA. And the management, you all know, conservative injection, surgical. So surgical, early, you could consider a cheilectomy. You could consider adding in a Moberg. We've heard the Youngswick. And then end stage, you're talking fusion or replacement in my book. So cheilectomy tends to be good for early disease, rapid recovery. The problem with a cheilectomy is 20% of them unpredictably progress. And why have 2 operations when 1 will do? So this is a recent long-term study on cheilectomy, 169 cases from Stephen Rakin in the US. So if you see 88%, i.e. 90% of these are really early disease. 6.5-year average follow-up, only 70% satisfaction rate. So 1 in 3 are not satisfied at 6 years with this operation. And the question becomes, would they have been better being tickled along with a cortisone injection so you can then do 1 operation, 1 good operation, rather than give them 2 cracks at the whip? Okay, what happens if you add in a Moberg? These are interesting cases here, interesting papers, both written and published in 2024, both published from Hospital Special Surgery, New York. Not clear whether we're talking about the same cohort of patients, written up by 2 separate groups of registrars, and you'll see Scott Ellis is on them both. And the first one analyzes that data to say that adding in the Moberg osteotomy doesn't change short to medium term outcome of a cheilectomy. The second one gives a slightly different slant to what must be the same set of figures, to say that adding in a Moberg improves, gives a greater change, and that's basically because that cohort of patients had a slightly worse preoperative score. So does a Moberg really work? The jury's out. I'm not convinced it adds much to a standard cheilectomy personally. Okay, so then we're into fusion or replacement. Well, fusion's a great operation, as is fusion of an ankle. So why would you consider replacement? Well, why have stiffness when you can have movement if you can get rid of pain? And this is what the ladies want to come in and see. And this is what they want. They want to go back into the high heels and be pain-free. And this is what you can expect if you do a joint replacement at 6 months. This was done bilateral, same sitting, and this is her at 6 months showing the range of movement you can expect with a joint replacement. So why have stiffness when you can have movement? We don't stiffen the hips anymore. We don't stiffen knees anymore. We've got good joint replacements. We've heard the skeptics' view of an ankle replacement. An ankle fusion is good, but an ankle replacement also gives you a pain-free range of movement. And what I'm going to do is try and introduce you to a big toe joint replacement and show you that similarly, you get great results with it. So fusion, you all know it, gives excellent pain relief, 7% symptomatic non-union. You've got a slow initial recovery because you're waiting 5 weeks for the thing to fuse. It can limit high heel shoes afterwards, and it can limit running, particularly in, long distance half marathon runners. It can increase stress on adjacent joints, particularly if you get a slight malunion. The distal IP joint is unforgiving and it can go on to hyperextension. And malpositions, which we do not talk about for fusion because we're only interested in union and then discharge, is an extremely difficult problem to deal with, as is excessive shortening following a fusion. So what are your options for joint replacement? Well, historically, we had a few. And what I'm going to effectively introduce to you is now there really is only one. So the Moj was out 20 years ago. It effectively has now been, it was a ceramic joint replacement on both sides. It didn't do well, it sunk, it cracked, and it failed. The Townley toe is an okay, it's this steel one here. The problem with the Townley toe in my book is it's replacing the wrong side of the joint. The diseased cartilage is on the head of the first metatarsal, and this replaces the base of the proximal phalanx. So then we've got the Silastic, we've got the hemicap, which was out about 15 years ago, which was the precursor of the Cartiva. So the hemicap is basically now withdrawn, as is the Cartiva. So that really just leaves you with the Silastic as a viable option. So I'm going to introduce that the Silastic is the best operation you can ever do. So let's go to the history, because you don't know where you're going until you've seen where you come from. So Swanson introduced the Silastic joint replacement now 60 years ago, and it was originally introduced as a hemiarthroplasty. Then about 10 years later, he changed the silicone to make it a high performance elastomer. And then in 1975, this is the one that you should be dealing with. It's a double stemmed hinge. So the implant is not a new implant. It's been out 50 years. And then in 85, he introduced titanium grommets for the end. So it's been out 50 years. Why are we not all doing it? Well, just like you, I was introduced that it was a device of the devil. It didn't work. People catastrophically hated it. And it would leave you with a short, floppy big toe. And because of that, we were introduced to historical reports of silastic synovitis, progressive cyst formation, loosening, and failure. So why am I doing it? Well, I inherited a practice that my predecessor had put a lot in. And I was seeing them in clinic, because at Wrightington, we never ever, or certainly 30 years ago, ever used to discharge patients. And patients were coming in 15 years after having one put in. So I sent them off for x-ray, hoping that it would show catastrophic failure. And the patients would come back and say, it's great. And the x-rays would look okay, like a 15-year-old hip replacement. And I was seeing more and more. So I went to the literature, and there's only 8 studies in the world literature that are negative on a Silastic, and yet that was enough to kill the joint replacement. And all those negative studies were on the single-stemmed hemiarthroplasty, like you see here. And they were in the late 70s and early 80s predominantly. And they were put in for a mixture of hallux valgus and hallux rigidus, and they reported what you traditionally hear. So what's the positive literature on it? Is there any? Well, yes. Since those negative literatures and the double stem was introduced, there's been 17 subsequent studies in the world literature over the 30 years. So that's one every 2 years. They report the double stem Silastic. They report them for predominantly hallux rigidus, but early studies were putting them in for hallux valgus. And all but one of those 17 studies report good or excellent results. So we've got a database in that study, a cumulative database of almost 1,300 patients with follow-up averaging, totaling around 1,400 months. So each paper averages, therefore, 81 patients with 86-month follow-up and an 87% satisfaction rate, which is not bad at all. So let's go to the papers. Swanson, his early paper, 1979, 165 feet, average 4-year follow-up. Put them in for a mixture, rheumatoid osteo, some hallux valgus. It was a mishmash of patients. 20% revision surgery rate in rheumatoid because they got recurrent hallux valgus, but an 88% satisfaction rate in OA. Then 1980, a year later, similar outcomes. So the results are different for OA and RA, and the results are certainly different for neutral OA and hallux valgus. So let's go to the negatives. These were quickly followed by 4 negative papers. In the 1980, 7 feet, not many, They got reported synovitis of the wound, 71% revision rate. Everyone had cystic formation. There's no other paper that's found that, but these are for the single-stemmed implant. 1982, reactive synovitis. 1989, single-stemmed implant wear and osteolysis. 95, single-stem implant, poor result, and 93, granulomatous reaction. So the hemiarthroplasty, which has been withdrawn from the market now for a long time, is where the bad results came from. So the conclusions of those 5 papers were that you get a lot of silicone wear debris, you get synovitis, you get bone erosions and cysts, loosening and implant fracture, and these all related to the hemi implant, which should not be used. You can't use it anymore, it's been withdrawn. So let's go to the positive results. They introduced then the double stem, and here we are, 91, 106 feet, 2.5-year follow-up, 88% good results. 1990, 228 feet, 90% good results, 1% revision for pain, 2.5% wound inflammation rate, and no implant failure. 92, 37 feet, some rheumatoid. So again, a mismatch, 82% satisfaction rate, worse rates with rheumatoid. 92, 67 feet, 6-year average follow-up, 87% good results. 2003, 42 feet, again a bit of a mishmash, 90% satisfaction rate. 2008, 76 feet, 85% pain relief. Here's 2011 and 2013. So the reports still come out. Here's 19-year average follow-up, 90% satisfaction on 43 cases. So I looked at mine. I'd been putting a lot in. I had 108 consecutive cases, no case lost to follow-up, mean age at implant 61.5 years, average 5.3% year follow-up with 2 to 14 years. VAS scores reduced from 7 to 1.3, and MOX-FQ dropped from 80 to 10. We had a 97% survivorship at 5 years, which clinically is exactly the same as the best joint replacement in the body, which is a hip replacement. So it is a good joint replacement if put in for the right indication. So the conclusions from the literature is that the double-stemmed implant has a high satisfaction rate with minimal implant failure, minimum synovitis. You do eventually get bone cysts, but they're clinically asymptomatic. You mustn't use it for a bunion, for hallux valgus, because it will recur. And the jury's out as to whether you should use it for rheumatoid. And I would suggest you wouldn't. So in those 30 years, there's been 17 studies which are backing the implant. Okay, so what would I consent them to then? So it's day case surgery. Both sides can be done at the same time. It's woolen crepe bandage, your immediate weight bearing, and you can get a predictable good result of 93% 10-year survival on the implant. 2 weeks in dressings, and at 2 months, they're into their own shoes and potentially into higher heels. And the concern is stiffness, swelling, and wear. So this is what you'll see at 3 months. You can see that the wound is still a little red, it's still early days, but that's how much movement you're going to get through the joint. That's on a hard floor. No. So what are the indications and contraindications? So ladies do really well with this joint procedure. Over 55 potentially, neutral hallux rigidus. They want movement and the concern for heels on the shoe wear, and they can be active in the gym. So your ideal patient, lady, 61, wants to keep the joint flexible, wants to wear high heels, end stage rigidus. Don't do it for hallux valgus. So if you've got a significant hallux valgus with OA, then that's going to have to be fused. And caution in the young, active, caution in the males, and caution in the rheumatoids. So the take-home message on Silastic is it'll give you excellent pain relief, predictable rapid recovery. It will preserve the arc of movement that they currently have at the toe. There's a 93% 10-year survival. It is very reproducible. It gives excellent cosmetic results, and there's a high patient satisfaction rate. So here we go, Hall of Fame, 26 years. So yes, there are a few cysts, but if you take an x-ray of a hip at 26 years, you're not going to get a perfect looking hip. So these are not any significant problem, but have been overemphasized in the literature. So in my book, fusion versus replacement, why would you fuse it when replacement does everything and gives you the movement back? Replacement has a faster recovery. You're not waiting for bony fusion. It preserves movement, so there is zero issue with shoe wear, minimal bone resection, and you get an excellent predictable long-term outcome. So, summary. If you want to play with the joint and you want to give them an unpredictably painful and stiff joint, then offer them a chylectomy. If you want a bulky fusion where you might need second surgery to remove the implant because of prominent hardware, then go ahead and fuse it with a dorsal plate. 15% further operation to remove the prominent metalwork. But if you want to surf the wave and live the dream, then in my book, give them a Silastic. Okay, thank you very much.
Tim, I think you have sold the Silastic very well. So we're going to have a discussion. So Alessio, if you can please switch on your camera as well and join the discussion. Thank you very much. Very entertaining as well as educational material here with both the talks. And we have got some questions. So let's kickstart with a couple of questions for Alessio. So the theme for your questions is number one, about people are asking about metatarsalgia. So do you get, are you worried about introducing metatarsalgia if we are shortening? And let's start with that. What are your thoughts about additional pressure on the lesser metatarsals after Youngswick?
So I agree that's probably the most important concern, even because every time I talk about Youngswick with someone who doesn't do that, it's the very first question. And I totally understand that. And my reply is the same, is that for a reason that I ignore, because I don't know why, like 80% of hallux rigidus I see are metatarsal plus. So actually, I very rarely concerned about too much shortening. At the beginning, I was in theory concerned, but in the end, after 5 years of practice, I can tell you that, but I don't know why, because also I must tell you that talking to other colleagues from Brussels, I think they were telling me like the opposite, which is very curious from an epidemiological point of view. I don't know if there is a study saying that hallux rigidus is more common or not, based on the first metatarsal length. Anyway, this is how it is in my practice. Like 90% are plus, and it's not a problem. Of course, like in the first, say, 6 months, like everyone gets a metatarsalgia, but there's not a true complication. It's just the adaptation. It's something I see also with medial osteotomies, at least in my practice. Like it's what I call normal reaction, because you have had the procedure on your medial column, you start walking again, but you still feel something is new, so you need to adapt to that. So you tend to overload a bit your central and lateral columns, and this is why your metatarsalgia comes from. But like most of them at 6 months, they are sorted. It's very rare that at 1 year or 2 years, I see a metatarsalgia. I never treat that during the first year. If there is a problem, I go with orthosis, so I start from 0. And it's rare that I have to go in there and do a DMMO. Like those cases are probably my mistakes, either in indication, because the first metatarsal was already too short and I was too aggressive in thinking about the shortening osteotomy, mistake number one, or mistake number two, like a technical mistake, because sometimes when you are there engaging, like I have to remove 4 millimeters and you have to consider the width of the saw, etc. Sometimes you want to do something and you can get out with like 1 millimeter more or less. If it's less, it's not a problem because you go for another recut. But if it's more, you have to accept what you have done. So this is another thing. And probably just the last point for this question is that it's very important the plantar flexion of the metatarsal head. So it's not all about shortening, but it's about plantar flexion. This is where I think that probably in the future, weight-bearing CT could be helpful for us to understand things, because in this moment, I'm unable to assess the plantar flexion properly. Like I use radiographs, of course, or I use unloaded CTs, but none of them could really tell me what I've done in terms of plantar flexion.
So, Alessio, can I ask you, so, I mean, if I remember correctly, so when Baruch introduced scarf osteotomy, I think the initial thoughts were to plantarflex the first metatarsal head. But then I think we talked a lot at that time, but we gradually moved away from plantarflexion. Then I think I heard Baruch saying that he said, no, you shouldn't be plantarflexing too much, maybe a millimeter or so. So that's where the confusion is that,
Yeah. But if I can interrupt you, I mean, with the valgus, you're not concerned about metatarsus elevatus. Like when you see that those plantar flexion was purely to try to unload the lateral column, but it was like starting from 0 going to -5, okay? But with Hallux rigidus, normally you start from +5, because if you look at your sagittal X-ray, you will see a dorsal movement of the first metatarsal. So I think it makes much more sense to plantarflex. I think you cannot compare the plantar flexion of a Youngswick or whatever osteotomy for an Hallux rigidus to an Hallux valgus.
Okay, fair enough. No, that I absolutely get it. And you have actually covered another question which people are talking about, index minus. So do you do it for index minus or you don't? That's a contraindication.
No, I don't. I don't think it's a format. I never found it in literature, but I don't. I wouldn't dare.
Okay. And thirdly, people have asked that, if somebody has metatarsalgia developed after the surgery or maybe had before the surgery, do you have to do lesser metatarsal osteotomy to make them short as well, to maintain the...
So I honestly don't. I must tell you, I tried, even for forefoot rebalancing, I try to touch the least I can at lateral metatarsals, at least in my hand. I mean, even in doing the MMO of 2, 3, 4, and 5, I try not to do that much. And that's the same for Hallux rigidus. So I tell them, I'll try to compensate that just plantarflexing the first ray, and most of the times I succeed for some reasons. If I don't, I'm happy to go back there and say I'm gonna do just a DMMO.
Okay, so what I'm going to do now at this point, before we get Tim in, I will ask you, Alessio, what is your algorithm for Hallux rigidus? So, do you do chilectomy? Youngswick, you obviously do, and joint fusion or any other procedure. So, do you have an algorithm?
Yeah, so just very, very, very simply, that's not my algorithm. I think it's borrowed from common literature. Like at the beginning, orthosis with just Morton's bar. I mean, it works. Sometimes it works. I always start with that. Second step is injections, just steroids injections, never hyaluronic acid or whatever else. Just that, just once. And if it works, okay. If it doesn't work, I'm never gonna repeat it. And then there is surgery. I mean, if the injection has worked and the duration is more than 12 months, I can repeat it. I can consider repeating, but otherwise I don't. And then there is surgery, and it's generally Youngswick. I have done some chelectomies, but in my hands, maybe I've never been so aggressive. I mean, at the EFAS Congress in Brussels, I have seen images of very, very aggressive chelectomies, like 1/3 of the joint, while in my training, I was trained not to touch the cartilage and those kind of things. Okay, so I'm not, probably it's my fault, but chelectomies in my hand, not very good. So I go for a Youngswick, or if it's a stage 4, it's a fusion. And if it's a fusion, I generally do miss like percutaneous because I don't need to open and see it.
Thank you very much. So Tim, coming to you, we have heard that chilectomy should not be performed. Do you ever do chilectomy?
I probably do one every 3 5 years. So I don't see early disease. I just don't see it. I think I can't remember a one. A one's normal in my book. I just don't see it. So I'd see later disease. So I have a chat with the patients. You know, it's in my armamentarium. It's an operation I don't like, only because, not because it's difficult, but I want an operation that predictably works for a long time. What I don't want to do is do an operation which unpredictably doesn't work, and they're back knocking on the door within 18 months to 2 years to say it's worse, it's stiff, it's this or that. So I'd be more down the road of, I'm going to keep them ticking along until they're ready for definitive surgery. So by that, I mean, I'd inject them. Now, I'd inject them only once a year. Okay. And realistically, the injection might help for 7 months, 8 months. And then, you know, they suffer it for another 2 or 3, and then they come back the next year. And I might get another 3 to 5 years out of that with an injection. I don't want multiple repeat injections. And then it's a case of they're usually having definitive surgery. So I'd only use chilectomy on fairly early disease with a prominent dorsal osteophyte that's rubbing on shoes and they've got classical pain at the extremes of dorsiflexion, certainly not on axial grind.
Thank you. There are a few questions coming up, so let me just take some questions from audience. So first question is, any experience with toe fit replacement?
So toe fit, I've no experience with. It's an implant that takes up the whole flipping toe. I mean, it's a big implant, so you've got to worry if and when that fails, how much bone have you got left? And the bottom line is not very much. So if and when Silastic fails, then you think, crumbs, what am I going to do? I'm going to have a big cyst, I'm going to have to fuse. No, you don't. It's no different from a failed hip replacement. Okay, so you pull the implant out, you remount, you fill up the stem because it's a contained defect, you put bone graft in, DBM, and you put in another Silastic. So my failed implants go from Silastic to Silastic, just like they would, you know, a failed knee or a failed hip.
Can I ask you a question, Tim?
Yeah.
Is a revision Silastic more difficult than a primary one?
It's an easy operation. That's why I love it. Predictable outcome, easy operation, and I classically say a blind baboon can do it. It is that easy. Okay. But I was trained to do it by the associate specialist, you know, who's been doing it for 10 years. See one, do one, teach one. It is exceptionally easy to do.
So, sorry, the question was, Tim, about revision.
Yeah.
Is revision easier than primary?
No, what revision operation is easier than primary?
But that was the question Alessio asked you.
Not a difficult revision, because the implant you can just lift out. Then you've got a hole. You just you take out the biofilm from the stem, ream the stem back up, and put in the next size implant up.
Okay. So another question is, so we heard your thoughts about toe fit. How about, do you use grommet for the replacement?
So no. So grommets. So again, why did grommets come in? So you've got to go to the literature. So grommets didn't come in because great thing to do. Grommets came in because the last negative paper out, and then the writer hypothesized that the cysts were caused by the sharp bone ends rubbing on the implant. So Swanson then thought, right, I'll knock that on the head. So he created metal grommets. And then 2 years after they were introduced in 1985, a very dodgy paper came out to say, the results of that there's much less cysts when you use grommets than when you don't. It was a really dodgy paper just to answer that question. Now, why don't I use grommets therefore? A grommet, if you look at it, has a very sharp metal back to it. So if anything is going to cut through a plastic implant, it's going to be the metal grommet. The metal grommet has no binding on, it's just literally a Dutch cap on the end of, bone. It's just sitting there. Okay, so I don't use it. The chap who trained me never used it. All those 100 patients who had inherited didn't have a grommet in. They were all doing well. I saw no reason to use the grommet. So I've never used a grommet. They go straight in the bin.
Okay, good. Thank you. You did talk about contraindication, hallux valgus being a contraindication. So a question from audience is, is there any degree, how much hallux valgus can you accept? 5 degrees, 10 degrees, or nothing?
So this is a really easy question, and everybody gets concerned about it. Okay, so it's what when people ask me that, they're looking at X-rays and they're treating X-rays and they're drawing lines on the X-ray. And what I say to those people is, have a look at the patient. What is the diagnosis? And it's very easy. The diagnosis is either hallux rigidus, or it's a bunion, with arthritis. Now, if it's hallux rigidus, very, very rarely, almost always, the toe is straight. It might have a minor degree of valgus, but the underlying problem is hallux rigidus. So I would use, without any difficulty whatsoever, a Silastic on that. So I never measure angles. It won't be that valgus. If it's a bunion, it cannot have, and that's your primary problem, it cannot have a Silastic. And certainly if it's a bunion, if it's a bad bunion with arthrosis, that has to be fused. So I don't measure angles. I work out, is the primary problem hallux rigidus? And if it is, then I can correct any minor valgus, radiological valgus, either through my cut or through plicating the medial capsule, and the toe goes beautifully straight.
Good, thank you. So what I'm thinking is, we talk quite a lot that if the toe is very stiff, and Alessio also alluded that, so if it is very stiff, then you're not able to gain movement. Is that right? Is it, if you have hardly any movement, can you still get excellent range of movements as you have shown with the Silastic?
Yes, because you put it in sloppy. You don't put it in tight. The sloppier the better. So there is a bit of give. So your cut is just like, if people were brought up doing knee replacements, when you did a knee replacement, your cut on both ends is a box shape. It's a rectangle. And similarly here on the big toe, you've got a rectangle, which is a depth of, maybe a centimeter and a half. And the implant might only be, in that hinge, might only be a centimeter. So you've got a bit of play and wobble. So it's moving. So even though you close a capsule and then you get some degree of fibrosis, it's moving. That's why there are different designs for this implant. I'm not got any financial gain on any of these designs, but there is an alternative design with a shorter stem. Now, the Silastic did come out with a short stem device. Now, for me, I've seen some short stem Silastics that are painful. And you've got to work out why when the longer stems aren't. And I think you need the longer stems to get adequate fixation in the bone, and the shorter stem doesn't give you that because you're making it sloppy through the interface. So you want the stems tight.
How about your post-operative protocol, weight bearing and all that? Straight away weight bearing, full weight bearing?
this is it's so easy. So into woolly bandage, immediate weight bearing is tolerated. So they're all done under block. So they wake up, there's no pain in the foot. They're walking out of the hospital, no pain in the foot. And then they take them regular analgesia for the first 2 or 3 days. Then the surgical pain is gone. Okay. At 2 weeks, wound is healed. They're then into a trainer. So Alessio is saying, okay, it might take 6 months for his Youngswick to calm down. They have a bit of metatarsalgia. They have a bit of transfer. They have some swelling. You saw my results at 3 months, bilateral. You know, the foot, the great thing about this operation is, like a knee replacement that you see at 6 weeks, the arthritic pain has gone. You've got rid of it. It is gone at 2 weeks, and then you can get them going, and they can load that big toe really quickly. So the time taken to get from A to B is fantastically fast.
Great. You talked about your ideal patient as 55 years old plus female with a straight toe. How about 40-year-old male who is very active? Would you do Silastic on him?
So males, so this is the fine print. Males do not do as well. So I have that conversation with them. So I can say, right, okay. So the females want different things. They want shoe wear. The male wants the pain to go away. Okay. So, you know, he's not normally varying the height of his heel at the weekend. He's not in high heels at the weekend. So what's the advantage of movement for him when he can have everything with a good fusion, pain relief, and it's set to a standard heel height? So I don't think the joint is robust enough for an active male, personally.
So in that sense, then, it's very clear then what you have said. For males, you will do a fusion. For females, you'll do Silastic.
Yes. If you look at my paper, if you look at that paper, I think, what was it, 118 consecutive patients. 4 males, 104 females. And that's just with discussion with the patients. Okay, so this condition is 4 times more common in females than males, if you look across the spectrum in terms of what people are doing. So you will see more females for the first M2 PJOA end stage. But I tend to do much more fusions for males and virtually every lady is having a Silastic.
No, that does make sense. Look, I think, Tim, you have sold, I'm sure you've sold Silastic to a lot of people. I'm tempted to try. I haven't done one, but the way you've described, I think it's worthwhile to try. And again, Youngswick, Alessio, you very beautifully demonstrated, what are the indications and why you do it. And obviously there is a role for, especially if you get an index plus dorsiflexed metatarsal, that's an option one must think about it, which is underutilized, I must say. Osteotomies in general are underutilized. I think we are bang on time and we had a good discussion, and I thank you very much for giving your time and giving these excellent talks and educating. And thank you so much on behalf of BOFAS, and I'm sure we'll catch up very soon. To the listeners, you will get feedback. So please fill back the feedback and you will get the certificate automatically. And look out for the next date for Master Techniques. We'll be holding it in a couple of months, and suggestions are welcome what you would like to hear. Thank you very much and good night, everyone.